Hello, my name is Gary Capistrant. I'm Chief Policy Officer of American Telemedicine Association. Going to talk to you about U.S. telemedicine public policy. First of all, we'll talk about, give you an overview of telehealth tools and uses, some information about the context that we find the telemedicine in, and then some of the key issues for growth of telehealth use. There are a lot of strong demands that consumers have. We increasingly want something available 24/7, on demand. We want it convenient, easy to use. There are lots of drivers for telehealth. The aging population adding to demand, concern about costs, provider shortages. We get more familiar with the technology. The providers of healthcare get more familiar with it, and then the ubiquity of telehealth. Major telehealth uses or means are basically four: video conferencing, real time. If this was like a television show, that would be like a television news show. That's real time synchronous. What we're doing would be considered store and forward. This is being recorded. You're listening to it at a different time. Also remote monitoring of patients with chronic conditions, and some use of robotic services. There are a lot of terms used for telehealth, telemedicine, mHealth, eCare, a whole variety of things that all essentially mean the same. Sometimes there are fine differences, like mHealth to us means that it's a healthcare service provided using a mobile device. And I should start or say that to us, telehealth is merely a healthcare service provided to a patient from a provider who is at another location. We prefer not to get into the technology, all kinds of other variations. So there may be those fine uses, but sometimes it gets confused with electronic health records or health information technology in general. The goal is to move to simply healthcare and to have it be considered health, just as we don't talk about in-person health services. At some point, the telemedicine goes away as a term. It's a wide range of applications, just as there are a wide range of health applications. And it's important that while we, as an association, we can get involved in technology, that the important thing is what the solutions are for people. It's not new. It's been varying estimates of when it started, going back like 30, 40 years. Some would put it earlier than that. It's not clinically different than an in-person service. In fact, it's not even a service. It's a way of delivering a service. It's not like dental as a separate service or a separate service category. It's a way of delivering any other service. In fact, there are uses of it in the veterinary field, just as there are with humans. It is not rural only. There are lots of applications in metropolitan areas. People in metropolitan areas can have just as significant barriers to their mobility to getting to a provider. And again, it's not about the technology. So there are a wide variety of not only applications, but where we are with regard to various applications. It's very well established in radiology and pathology. In fact, so much so that we don't even talk about really teleradiology or telepathology. It just happens. You go to many hospitals in the country at 2 o'clock in the morning, your CAT scan may not be read by a radiologist who's in the building. The radiologist may be at home, they may be across town, maybe across country. You don't know, you don't care. It's not even usually called telehealth again. It's just having the procedure done. Some other kind of mid-range uses are for remote diagnosis of stroke, where time is critical factor, and so any hospital in the country should be able to diagnose a stroke within an hour as to whether the person is having an ischemic stroke, and you can start clot busting therapy, or they're having a hemorrhage, and that's the last thing you'd want to do. With regard to monitoring of patients and serving patients who are in an intensive care unit or other kind of critical care unit. Newer examples are remote patient monitoring, again, of people with chronic conditions, and rehabilitation. There are lots of barriers, and one of our chief goals in terms of public policy for American Telemedicine Association is to remove and oppose artificial government barriers. There's all kinds of barriers that that come into play, and we want to remove those. There are lots of roles that government plays. These are examples at the federal level. Very often these are at the state level as well. A good example of rendering is Veterans Affairs or Department of Defense. Reimbursement, the major agency we think of as the Center for Medicare and Medicaid Services, but there are others. Regulation, good example being Food and Drug Administration. Research, National Institutes of Health. Resources, Health Resources and Services Administration. Readiness and Recovery, Federal Emergency Management Association. So one of the things is with these multiple roles, sometimes the agencies have inconsistent or maybe even conflicting objectives. So one of the things is to try and get the federal government working together as much as possible. Sometimes you get federal investment, like on community health centers, that then isn't necessarily supported by federal reimbursement for those services, like the Medicare program only reimburses community health centers in rural areas, not the majority that are in urban areas. So one of the things is, in terms of public payers, Medicare is we think of as basically a no, and Medicaid is a go. Medicare is restricted by statute. Section 1834M of the Social Security Act have the restrictions in there. We'll be talking more about other places. They talk about physician services that is not considered telehealth, and then the Center for Medicare and Medicaid Innovation has some opportunities to move forward with the use of telehealth services for Medicare. Medicaid is a much different situation. There is no federal law or regulations that restrict the use of telehealth. A state can do whatever it wants in terms of the coverage of telehealth. And in fact, there are some common requirements for Medicaid, like that if you offer a benefit, it must be statewide unless you go and get a waiver. And so it's very different than the Medicare program, where that barrier is part of the statute. The Medicare program is essentially two different programs today. One is for fee-for-service medicine. You see about 70% of the Medicare beneficiaries are in that. The government has objectives to shrink that number, to increasingly move people into Medicare Advantage plans, which is Medicare's terminology for managed care, or some other kind of value-based reimbursement. It's important to mention that the Medicare Advantage plans can do also what they want on telehealth. There are some restrictions in the way CMS has the bidding process that some of the Medicare Advantage plans will say acts as a deterrent to their covering telehealth. And importantly, there are over 2 million of the beneficiaries that are in a subset of Medicare Advantage called special needs plans. These are plans focused on particular diseases or conditions of the patient, like the dual eligibles. We can talk a little bit about the barriers that are in place for fee-for-service. One of the things is limited coverage of live video. You've got to be in a rural location. Limited in terms of originating sites. You have to be at a healthcare facility of some designated type. Importantly, you can't be at home. limited use of providers. The major providers who can't do telehealth and Medicare to the extent that they're otherwise covered for Medicare are the therapists, physical, occupational, speech, respiratory. And then Medicare is one of the payers that gets down to only covering certain procedures that are part of an approved list, as opposed to just relying on provider judgment. There's essentially no coverage of store and forward, and essentially no coverage of remote monitoring for chronic conditions. There are two major bills that are pending in Congress right now, the Telehealth Enhancement Act and the Medicare Telehealth Parity Act. You can see one is a Republican, one is a Democrat. Both bills have bipartisan sponsors, and one of the things about telehealth in general is that it's usually a very bipartisan issue, and that applies at both the federal level but also at the state level. One of the things that we try and do is focus a lot of attention on the specifics of state coverage. A lot of activity. Many of the states are much further along with their Medicaid program, for example, than Medicare. We recently published two analyses, one on coverage and reimbursement, another on physician practice standards and licensure. These are updated about every 6 months, and they provide useful information to states on specific ways in which they use telehealth, and then we get into grading states, A, B, C, F, and so a state can easily see who the leaders are and who the laggers are. So we'll get into some of these. One of is in terms of overall coverage. We see you want to be in a blue state, one of the A states. There are 5 states in DC that get an A in our grading, and there are 2 states that get an F. One of the things is we focus a lot on parity, and for us parity means that the coverage is the same as for in-person care, and the reimbursement is comparable. So there are now 29 states that have some kind of parity law on their on the private insurance policies that are offered in those states. The Medicaid plans will vary in their coverage. They all cover imaging like radiology and pathology. 48 states cover something, but that something can vary greatly once you get beyond physician services by video in rural areas. Then the coverage breaks down. So you can see only 13 states specifically cover store and forward. Important for Medicaid is that many of the recipients, particularly mothers and kids, are in a managed care plan, and those plans should have the flexibility to use telehealth, particularly when the plan is at risk for the finances, and be able to use telehealth to create value. So here's our grading of the state's Medicaid. The A states are in blue. That's 4 states and DC, and then there are 5 states that are in F. A couple of states have parity requirements for their Medicaid plans. This year, for example, Tennessee did a law for coverage of parity for private insurance, for Medicaid, and for state employee benefits. States also vary in their physician practice rules. In addition to the medical boards in every state, there are licensing boards for other professions, nurses, psychologists, physical therapists, for example. This is in terms of physician practices. Again, the blue state are the A states, the 22 A states. There are several delivery problems that we try and address, and to use telehealth specifically to address some of the intractable problems that are common in the healthcare system, such as physician shortages. It's very difficult to recruit a psychiatrist now, even if you're a prestigious academic medical center, much less trying to get that services, psychiatric services, to far-flung parts of the country. Telehealth is a way to do that. The technology allows for greater use of those scarce resources and creating access to people more broadly. So all kinds of things that telehealth can be used to improve provider productivity. One of the things is, for example, it's hard for a physician to have a brick and mortar practice and do it on a part-time basis, but telehealth can easily be part-time. And so whether it's a physician that wants to be at home raising children or wants to be semi-retired, that telehealth is a way to use their expertise to continue to serve people. Certainly there are added advantages to it. One of them is that 24/7 aspect. The doctor's office is Monday to Friday, 9 to 5. That's only a quarter of the time. And so what happens with the healthcare issues that come up in the other 3/4 of the time? Lots of economies of scale to garner with the different ways that you can configure a network, and all kinds of ways with improving technology to deal with cost and quality. It's useful to think of some of the opportunities that with telehealth. We put an increasing emphasis on patient choice and outcomes, convenience, satisfaction, but also moving to the innovative payment and service models. The innovative payment, we often talk of, these are some terminology that's used. Sometimes the method may be something that mixes, does a combination of these, but it's getting away from some kind of fee schedule for a particular service. There was a time that the physician fee schedules that are now so common that they were an innovation. But that was quite a while ago, and we can do better than that now. In terms of the Medicare program, I think what we're going to see is emphasis on the payment innovations, accountable care organizations, bundled payments for an episode of care, medical homes that are primarily focused on primary care, but can also be used for chronic care and specialty care. Innovations with the Medicare Advantage plans, with community health centers. Some transition to deal with those patients who are duly eligible for Medicare and Medicaid, that they tend to be the high utilizers of healthcare, the high cost patients, and there are ways to deal better with making Medicare and Medicaid more seamless than what is often the case now, where it's a cost shift game between the two programs. Some things to expand telehealth within the fee-for-service world, like stroke diagnosis or diabetes education. One of the things that we've done also is published state best practices for telehealth uses. These are available on our website for free, just like the GAPS reports that I had talked about earlier. But you can see here the specific uses in each of these reports that usually are about 10-12 pages. We identify the leading states and also a state that isn't leading, how they can kind of a menu of options that they can use to move forward. In terms of Medicaid, I think we're going to see a lot of interest in parity, covering urban recipients just as the rural recipients are. There's a lot more interest in moving services into the home rather than just a physician office and other kind of health establishment. more flexibility for managed care to be able to use telehealth, interest on remote monitoring, and then focused initiatives like the way that autism, for example, can be serviced with a network of centers of excellence that can be a resource to not only the kids with autism, and now we're getting young adults with autism, but also their parents. That very often it would take a large metropolitan area to support an autism center, but certainly when you look at multiple states, you can quickly use the technology to virtually aggregate those people into a particular use. The use of telehealth for chronic care, and then to get to other sites of healthcare like school-based centers. We're going to conclude with a discussion of licensing. That's a big barrier right now. Basically, for all the health professions, you need to be licensed at both ends of an interstate encounter. So the state-by-state licensure is still very much a barrier. It's not like our driver's license that each of us has only one driver's license, but that allows us to drive in all the states. Right now, to deal with the interstate aspect, there are two kinds of licensing compacts. One is an expedited licensing that would still require that you have a license for each of those states, but there would be a process to expedite that and theoretically lower fees. This is an approach that the physicians are pursuing. There are other compacts based on reciprocity that the nurses, psychologists, and we soon expect the physical therapists to be pursuing that kind of a model. At the federal level, there's also a one-state license model that is used. This applies to Department of Defense by practice and by law. It's also one that many federal agencies use by practice. As a federal agency, they get to set their own rules, separate and apart from what state laws are. So VA often uses the one-state license model, Indian Health Service, other kinds of entities. And there have been proposals to expand that to other federal agencies, but also other federal health programs like Medicare. And so it's an interesting issue. In terms of the interstate involvement, while telehealth is kind of the prime example of where it's an issue, this applies to all kinds of other situations other than telehealth. We all travel a lot. Our providers travel a lot. We've got multi-state health plans, multi-state employers, and that whole notion of the state-by-state licensing as a barrier is one that we can do better on. A lot of this information is available, and a lot more is at americantelemed.org, the main web page for the American Telemedicine Association. We also put a lot of this into a wiki, atawiki.org, and then you can see my email and phone for any kind of follow-up you would like to have. I appreciate your interest in telehealth, and look forward to you helping us to use telehealth in a much more constructive way for 21st century healthcare delivery improvements. Thank you. Bye-bye.